Okay, today I will also be talking about infectious diseases and how they develop at different stages of migration. Now, the content that we're going to cover is based on an expert review by Greenway and Castelli, published in the Journal of Travel Medicine, and it offers one of the most comprehensive views of the health challenges faced by migrants, challenges that are deeply intertwined with the very structure of our global systems. So human migration is new. We've said that in on all videos. Now, throughout history, from the Silk Road to transatlantic voyages, the moment and movement of people has been a vehicle for the spread of disease. But in a very modern, hyper-connected world nowadays, migration has increased in both scale and speed. By 2017, there were over 258 million international migrants, and a quarter of them were forcibly displaced by conflict, persecution, or disaster. Now, crucially, most of these migrants are coming from countries where infectious diseases like tuberculosis, hepatitis, HIV, and parasitic diseases are far more prevalent than in their host countries. But that doesn't mean that migrants are simply carrying disease. Instead, their risk is shaped by exposure, access to care, and systemic inequities, and it varies significantly depending on which stage of migration they're in. Now, there are different stages of migration, and we can think of them as three different ones that we've talked about before: pre-migration or pre-departure, the journey itself, arrival, and then we can add a few more ones: early settlement, long-term settlement, and return travel to the country of origin. Now, each of these phases brings its own unique exposures and vulnerabilities. So, we can talk about each stage. What risks come first at arrival? When migrants first arrive in a host country, the most important factor influencing their infectious disease is what they're exposed to in their country of origin. If they come from a region with high rates of tuberculosis or hepatitis B, that risk comes with them. But not all migrants are the same. Refugees, for instance, they often undergo long, hazardous, and irregular journeys, and this means that they are living in cramped, unsanitary conditions, exposures that can lead to respiratory, gastrointestinal, and skin infections. Now, in contrast, economic migrants on planned journeys typically face fewer health hazards in transit. Now, host countries like Australia, Canada, and the US often screen for active tuberculosis before migrants arrive, and that's a good start. It's decreased tuberculosis cases in the early months of settlement, but many other infections go unnoticed until much later. If we talk about the early settlement stages and crowded camps and outbreaks, we can picture the early days in reception center of a refugee camp, for example. Here, people might live for weeks or months or even years tightly packed in quarters with very poor hygiene. Now, in this settling, outbreaks are not only possible, they're expected and unpredictable. Now, there have been real outbreaks of measles, varicella, which is chickenpox. I don't know if I have to translate that. Scabies, and even loose-born relapsing fever in these settings. Now, respiratory and gastrointestinal diseases, they spread very fast. Surveillance systems that detect symptoms early, what we call syndromic surveillance, are critical tools for containing these diseases. And tuberculosis remains a top concern here. Not only is it potentially deadly, but it's also transmissible in the air. And that's why chest x rays and symptom screening are done upon arrival. Now, as migrants begin to rebuild their lives and find homes and jobs and schools, another shift happens. The risks don't really go away, they just become less visible. Now, many migrants carry chronic infections without knowing it. Latent TB, tuberculosis, chronic hepatitis B and C, and many parasitic diseases like Chagas or strongyloidiasis. Sorry. Can lie dormant for years, now only surfacing later with serious consequences. Migrants are also more likely to be infected with HIV after arrival due to post-migration vulnerabilities like poverty, unsafe houses, or very limited healthcare access. Now, the real tragedy, these conditions are often treatable or preventable, but legal status, language barriers, cultural stigma, and the cost of care prevent a lot of people from getting tested or treated, and this leads to preventable hospitalizations, disease transmission, and even death. Now, let's zero in tuberculosis for a moment because it is one of the most clear examples of how migration and disease interact. Now, migrants now account for more than half of all tuberculosis cases in countries like Canada, Australia, and parts of Europe. But here's the catch: most of these cases aren't from active transmission, they're from latent infections acquired years before, often reactivated by stress, malnutrition, or weakened immunity. Now, this is where targeted screening and treatment of latent TB becomes essential. We have short course treatments now that are effective and cost efficient. The only challenge, or if it's only, is in reaching those who need them. If we take into consideration hepatitis B and C, infected individuals from endemic countries may carry these viruses for years without symptoms. Now, if untreated, they will develop liver failure or cancer. The problem: most countries don't really screen for hepatitis as consistently as they do for tuberculosis. Now, HIV and other sexually transmitted infections are also a concerning trend. Many cases are acquired after migration due to risky behaviors, trauma, or exploitation during the journey. Now, women in particular, they face higher risks of sexual violence in transit, which is rarely discussed but extremely important because it leads to the propagation of these infectious diseases. Now, there are the diseases that we also rarely hear about in high income countries: Chagas, schistosomiasis, and strong dialysis. Now, take Chagas for instance. This is a parasitic disease common in parts of Latin America, and it can remain silent for decades and then suddenly cause heart failure. Now, among Bolivian immigrants in Europe, the infection rate is as high as 28%. But because few doctors in Europe are trained to look for it, only 1 in 15 infected people are diagnosed. These diseases are treatable, some with a single dose of cheap medication, but only if they're caught in time. If we fast forward several years where a migrant has built a life in this new country but decides to visit family back home, these travelers are at high risk for infectious diseases like malaria, typhoidea, and hepatitis B. Why? Because they often travel for longer, they stay in rural areas, and they skip pre travel medical advice because we don't know about it, we don't educate on it enough. They may not realize that they have lost immunity or that they never actually had it. Children born in the host country are particularly vulnerable. Now, ironically, these people that are visiting friends and relatives, they are less likely to seek vaccines or malaria prophylaxis than tourists, and it's a blind spot in our healthcare system that needs urgent attention. So, what is the solution? Well, first, we need responsive, migrant friendly healthcare systems. Services must be linguistically accessible, culturally respectful, and available regardless of legal status. And secondly, we need to standardize screening protocols. As the article outlines, targeted screening for latent TB, not only for that, but viral hepatitis, HIV, and parasitic infections, is both clinically and economically justified. Third, vaccines matter. Across all stages of migration, from arrival to settlement, vaccines against measles, polio, hepatitis B, and more should be updated. This prevents outbreaks and saves lives. And finally, we need to train healthcare professionals to recognize the unique risks that migrant populations face, because infectious diseases don't travel alone, they travel with people. And people, no matter where they come from, they deserve access to health and dignity to treat these diseases. So there's a huge responsibility, not just in clinicians, but societies, to meet migrants with knowledge, compassion, and care. Thank you for listening.